Montana Pain Initiative. So I'm glad to have this opportunity to introduce Marc today. So Marc Mentel is a graduate of Michigan State College of Osteopathic Medicine with a Navy scholarship. He interned at a Navy hospital of Charleston and went on to serve as an undersea medical officer with the Navy and attended diving school and submarine school. After completing his Navy obligation, he returned to residency program in Aurora, Colorado and became board certified in family medicine. His initial practice site was with the National Health Service Corps in the health profession shortage area in the Upper Peninsula of Michigan. Since then, once completing this, he completed a fellowship training in OBGYN at Harrisburg, Pennsylvania, and then practicing in Colorado, and for the last 12 years in Montana. He served as the medical director of the community physician group in Missoula and now serves as the osteopathic director for the residency program. He's been active with the MMA as a board member and with Know Your Dose campaign. He is now here to represent the Montana Pain Initiative as the planning board chair.
Thank you,
Please welcome Marc Mentel.
Thanks, John, for the nice introduction. And we'll start with what we usually do is disclosures. And as you can see, it's a blank slate, so it means I really have nothing to disclose. The one disclosure I will make, though, is I'm not a pain management specialist. I'm a family medicine specialist. And I practice medicine that's relevant to families here in Montana and the families I take care of. And when you think of pain, it's probably one of the most relevant things to families. You think 1 in 3, 1 in 4 patients will present to their primary care doctor because they have something painful. It makes sense. The body tells the brain something's wrong. It sends that signal as a pain signal. Patient says, okay, I need to do something about this, and they go to their doctor. It also makes relevance in that about 11% of my patients will suffer from a chronic painful condition that affects their ability to live a quality of life. And then there's also about 1 in 100 patients will actually suffer from an opiate use disorder. So when I think of chronic pain, think of pain, it's relevant to what I practice in family medicine, which leads me to the Montana Pain Initiative. The Montana Pain Initiative is a conference that occurs every 2 years. It's been occurring here in Montana, or in Missoula here. I think this is the 7th semi-annual conference. It's a collaboration of everyone across the state to come together and talk about pain and how we manage pain here in the state of Montana and how we take care of our community members and everyone else that participates, or all of our citizens here in Montana. It incorporates people from all disciplines, so from physicians to nurses, physician's assistants, nurse practitioners, physical therapists, behavioral health, palliative care, and patients as well, to incorporate them into, let's talk about pain, see what we can do that maximizes function and eliminates or tries to minimize risk of harm. So before I segue into the part that I want to get to, I want to set a background. I saw this slide about a year ago, and I looked at this and said, back in late 90s, we started a conversation called Pain is the Fifth Vital Sign. And really the purpose of Pain is the Fifth Vital Sign was to bring pain from the shadows and let's start talking about it. However, as we started asking the question pain to all our patients were thinking, oh, there must be an answer. And the answer came as opiates. And since 1999 to now, we've quadrupled the prescription of painkillers in our country. And now we consume approximately about 70 to 80% of the world's supply of pharmaceutical-grade opiates. But when you look at the overall data, patients are still reporting the same amount of pain, even though we're prescribing more drugs into the system. So we need to reassess, need to reevaluate how we manage pain. While opiates may be part of, or may be a tool that we can use, they are solely not the answer. And so what we're going to do today is kind of an old school presentation. It's going to be myself and a patient I recently had a chance to meet on a radio program called Homeground on Montana Public Radio. Thinking of all the issues that go with pain management, going back to that previous slide, you know, you look at all the things that have happened since we quadrupled the sale of opiates. It's actually a made-for-TV docudrama when you think about it. We got big money exchanging hands. We got big pharma making a lot of money off of sending us extended-release opiates, but then they also sell us the antidote for that in other medicines to get people off the opiates, as well as medicines to treat the overdoses. We have the black market involved. We have detectives involved. We have law enforcement. We have death. We have addiction. And in there are patients who are actually doing okay. And so with that segue, I'd like to introduce Tootie Welker. She is an individual I had a chance to meet when Brian Kahn, orator for Montana Public Radio, interviewed both her and I in regarding to opiates and the state of opiates in Montana. Tootie comes to us. She's a former executive director of a nonprofit organization dealing with sexual and domestic abuse. Is that correct? Yes. She's currently a chronic pain sufferer. She still remains active and is thriving. She just recently had a chance to drive the motorcade for Bernie as he was here in town.
Brad Pitt movie.
She's a lead organizer for, what's the name of it, for
The Montana Patients Bill of Rights?
Montana Patient Bill of Rights, there's that, but you were the lead organizer for Bernie.
Oh, Missoula for Bernie.
Thank you.
I run the Facebook page, so.
And she has a small little company that she organizes herself selling Montana-made lotions, soaps, with the Montana-made all organic, so, and chutneys, if I recall. Yes.
And jams.
And jams. Thank you. So.
I'm at the Caris Park, Clark Fork River Market.
So what we're going to do now, part of this, like I said, is going to be old school. If you remember, medicine had its roots where a patient and a doctor took the stage, and then we had an audience of providers. That's what we're going to do today. Tootie was a willing participant in this. And what we'd like to finish up, after I play the radio interview that Tootie and I took part in, we'd like to open up for questions and answers. And if there's not any questions and answers, I have a whole nother PowerPoint that I'm going to present, so that's a threat. So I expect good questions here. So this is about a half-hour program, and just sit back and relax. It's Brian Kahn tells a very good story.
Welcome to Home Ground. I'm Brian Kahn. In our age of wondrous cures for so many illnesses, it comes as something of a surprise to find one without. More so when the malady affects tens of millions of people. And perhaps most amazing is the intense and complex controversy concerning a class of medicines proven widely effective in treatment. The illness, chronic pain. The medicines, opiates and opioids, natural derivatives and man-made imitations made of opium. We have two highly qualified guests to discuss this issue. Dr. Marc Mentel, Associate Program Director, Osteopathic Curriculum, Family Medicine Residency of Western Montana, and Tootie Welker, former Executive Director of Sanders County Coalition for Families, a domestic and sexual violence program, and many years sufferer of intractable chronic pain. Many thanks to you both for joining us on Home Ground. Tootie, where'd you grow up? What'd your folks do?
Grew up in the Midwest. My dad was a salesman. My mom was a teacher's aide.
Where in the Midwest?
Mostly in Kansas until I left home at 19.
When you left home at 19, what were the central values that you'd learned in that family and that setting?
I would say stoicism.
How about education?
I'm the first in the family to have not only a bachelor but a master's degree. In University of Florida in Gainesville, finished the master's in 1989.
And the master's was in what?
Rehabilitation counseling.
Tell us, if you could, in summary form, about the shelter that you were executive director of.
It was a very small rural program in western Montana, Sanders County. Started on a $20,000 grant and left 15 years later with a $700,000 budget.
And the period of time we're talking about?
1995 to 2010.
What's your experience with intractable chronic pain?
I've had low back pain since my 20s and started seeing a chiropractor. It became chronic in 2003, and I've had multiple back surgeries since then.
Now there's pain and there's pain. I want you to describe to me as best you can what we're talking about when it's bad.
When it's bad is that you wake up every morning going, what is it can I do and what is it I have to do today? Some days my day is getting up and feeding the dogs and then climbing onto the couch. Getting up and doing a few things and then climbing back on the couch. It's a very self-limited, it's isolating. It makes it so I can't go out at night with friends, so my only socialization is my daily visits to the dog park.
It sounds like something like that could lead to depression.
Absolutely.
Have you suffered depression?
Absolutely.
Normally, when one has an illness, one goes to a doctor, describes the illness, and the doctor has some medicine to propose. Has that been your experience in dealing with this chronic pain?
It was earlier, before the opioid hysteria, as I call it, came to be. In 2003, when my pain became intermittent and turned chronic, I was able to access appropriate pain medication through the Montana Spine and Pain Center. I was up to 150 milligrams of morphine a day with 4 to 6 hydrocodone.
You were on the medication, opioid medication?
Yep.
It was not hard to get at the time. You said it began that way. It suggests that that's changed?
Yes, and without that, I would not have been able to continue running the nonprofit I did. In 2012, when I had to have the second surgery, it became more difficult to find people willing to prescribe opioids for pain. In 2014, I had my last fusion surgery early before it was really medically necessary because I could not find anybody willing to treat the pain.
Dr. Mentel, where'd you grow up? What'd your folks do?
I grew up in the Midwest as well, northern Michigan. My parents were small business owners, packaged liquor store near the Straits of Mackinac, in a very rural area of about, our population of our town was 300 people.
That's fairly rural, even in Montana.
Yes.
So where'd you go to school?
Went to undergraduate at a small Christian college, Methodist college in the southern Michigan called Albion College, and then went to Michigan State Medical School.
Why medicine for you?
Medicine for me was a great way for me to continue with what I think was our family's overriding interest or overriding principles, and that's service and people matter. And I thought medicine was the best way for me to blend my interest of science with applying it to taking care of people.
Those two central values, people and service mattered, were they modeled by your parents or just the community you grew up in, or intuition?
I would say modeled by my parents. And in the small area of a small rural area, you learn to help one another, and you kind of pitch in when neighbors need a little bit of help. So.
And how long have you been a practicing physician in my layman's language post-residency?
22 years, Brian.
And how did you get involved in this issue of pain management? You hold some other title. Your titles were getting long there, so I cut one out. What did I cut out?
I work with the Montana Medical Association in regards to prescription drug abuse, but also looking at ways that we can best manage and help our population in Montana deal with chronic pain.
You're listening to Home Ground, and I'm Brian Kahn. We're talking about the issue of chronic pain with Dr. Marc Mentel and Tutti Welker. How long have you been involved with this issue of opiates and opioids?
I would estimate approximately 3 to 4 years right now, Brian.
I'm going to read you some statistics and see if we're in the same ballpark as grounding the discussion. This came from the CDC guideline for prescribing opioids for chronic pain, 2016. An estimated 20%, this is quote, an estimated 20% of patients presenting to physician offices with non-cancer pain symptoms or pain-related diagnosis receive an opioid prescription. In 2012, care providers wrote 259 million prescriptions for opioid pain. That seems to me like a big number, both numbers.
That is correct, Brian. As far as a population of the U.S., we make up approximately 4.4% of the world's population, yet we consume 80 to 90% of the world's pharmaceutical supplies of opioid and opiate medications. At the beginning of the century, around late 90s, early 2000, we were writing about a quarter of the amount of opiates we were writing now. Current CDC statistics show that we have essentially tripled and quadrupled the amount of opiate sales. And when you look at overall consensus, how we've addressed pain, we have not made a dent in it. I think everyone's familiar with going to a physician and they're asked, what is your pain level today? Everyone gives a pain score. Over the past 15 years, the CDC has kept track of those pain scores, and even though we prescribe a large majority of opiates, we have not made a dent in addressing pain.
Let me read you another sentence in the same paragraph. Rates of opioid prescribing vary greatly across states in ways that cannot be explained by underlying health status of the population, highlighting the lack of consensus among providers on how to use the medication. Do you agree with that statement?
Definitely agree.
I want to see if I understand your position clearly. What you said sounded like we're using a heck of a lot more of this stuff and it's not accomplishing anything.
Yes and no with that, Brian. What we have is, and I will quote a recent New England Journal of Medicine article by Dr. Alford. Right now we're in a juxtaposition right now, and I think we're actually repeating history of what happened back in 1914. In 1914, there was the Harrison Tax Act, which taxed opiates, cocaine, marijuana, and other medicinals at that time. With that came increased scrutalization of physicians and legislation against physicians and penalties against physicians where physicians were jailed and even lost their license for prescribing opiates in inappropriate ways. The country went through a phase of not prescribing opiates to the point where cancer patients and even those suffering from acute pain weren't appropriately addressed. We're in that same position right now.
That's an amazing statement to me in the sense that we're talking about roughly 100 years later. You're saying that because of a political reaction to medication which has some addictive qualities.
Correct.
I would imagine it's very hard for you or any other physician to name an area of medicine where they're pretty much in the same place 100 years later. Is that a fair statement?
That is definitely a fair statement.
So that suggests that there are serious non-medical factors involved in this dynamic.
Correct.
Now, Tootie, you used the phrase earlier, opioid hysteria. Is that what you're talking about in essence?
Yes. What I mean by that is that we have lumped all opioid overdoses into one category. We're conflating chronic pain people in with addicts. If you look at the CDC and the different federal registries that talk about overdose deaths, very few are opioids alone. Almost always are benzodiazepines are included in those, alcohol misuse, and yet if you listen to what's being reported in the news, we simply say opioid deaths.
Okay, and you're arguing that that hypes the concern.
It misleads.
Okay. I'm reading now from the Federation of State Medical Boards on the same issue. While recognizing that adequate evidence is currently lacking as to the effectiveness and safety of long-term opioid therapy, this model policy, which is what this is I'm reading from, is designed to promote the public health by encouraging state medical boards to adopt consistent policy regarding the treatment of pain, particularly chronic pain, and to promote patient access to appropriate pain management. Now that statement in English sounds to me like an effort to say, okay, we got a problem, we don't have definitive answers yet, we need a rational process and standardization.
That is a fair statement, Brian. If I can go back with what Tootie was addressing, Tootie is exactly 100% correct. Right now, our medical providers, those primarily in the front line, such as family doctors, internal medicine doctors, nurse practitioners, physician's assistants, we're stuck between an anvil and a hard place. On one hand, society is asking us to curb our use of opioid medications, cut back because of the opioid problems that we have in our country. And on the other hand, we're asked to make sure we take care of pain in an appropriate and ethical way. At the time back, I'm going to go back to 1914. In that time, about 1 in 300 Americans were addicted to opiates at that time. Congress interceded, created increased legislation to restrict the use of opiates. That crisis pales in comparison to where we're at right now. Currently, there's about 1 in 50, 1 in 100 Americans suffer from an opiate addiction.
Are you including in the opiate addiction medicines prescribed by doctors specifically, as opposed to street stuff or stolen prescriptions?
This is just purely those people who are addicted. This is not patients who are in pain.
Okay.
And if you look at the opiate addiction, about 2/3 of that is comprised of pharmaceutical grade opiates. About 1/3 is on the street heroin.
Okay, now here's the question that it leads to me. If one takes that number as a combined number, and if one says to oneself, this reflects physician abuse with patients, we're going to crack down on those prescribing physicians, it leads to one set of enforcement policies. If one says that the prescription abuse part of this equation is very small, it leads to a different approach. What's the medical profession saying?
I would like to quote actually what Dr. Elford from Boston University, it was in a recent New England Journal of Medicine, and I believe, as well as many physicians, that education has the potential to both reduce overprescribing and ensure that all patients in need retain access to opiates. There is an ethical balance we need to manage and need to think about. If we follow a principle of medical ethics, which is founded on 4 basic principles, beneficence, non-malfeasance, autonomy, and justice, we should be able to come to that right balancing point of making sure patients have access to opiate medications in a way that they're not viewed as being suspicious for drug seeking or as getting suspicious behavior or stigmatized, as well as addressing those individuals who may be getting into problems with the medications or diverting the medications.
Tootie, what do you have to say to that? That says education is the answer to gradually correcting the problems.
I think there's some of that of education. I think there's a couple points that are important to make is that there was a recent study in June that looked at 26 other studies that 3.3% of chronic pain patients actually become addicted to their opioids. So it's a very small percentage of patients who, with chronic pain, who are using their medications appropriately actually become addicted. Number 2, when we talk about overprescribing, one of the pieces that, just like we would not set a set dose for what you can give for insulin. It's an individual amount. And what's happening with people on opioids is there's a particular enzyme, CYP450, on how you metabolize opioids. Some people need larger doses to have the same beneficial effect. And yet if we keep putting out these prescribing limits like the CDC is, it's going to curtail those patients from getting adequate dosage for adequate pain relief. If they say they need more, then they get described as being as a drug seeker.
Mark, what do you say to that?
Well, Tootie is correct. There's a recent study just came from out of North Carolina. We're still trying to learn a lot about opiates and how best to use them within the situation of chronic pain. I would like to think that, you know, as you had mentioned in the Federation of State Medical Boards, there's not great evidence to show their use. However, what we really have is a problem of we don't have enough evidence to show where they may fit. I had quoted that as a general whole as a population that they're not working, but I do believe there's probably subsets of the population where these opiate medications can be used appropriately. Getting back to Tootie's statement where 3.3% of individuals become addicted, that is true. Very few patients with chronic pain become addicted. The North Carolina study showed that as you increase the doses of opiates, your risk of death increases, but there's no specific point of saying where that occurs. It's not a curvilinear approach, it's more of a linear approach.
The doctor's pointing out that the statistics are not clear as to the number of patients who are helped by opioids. Are you one of them?
Absolutely. And the WHO has actually what they call an analgesic ladder that they look at in prescribing opioids. And the first thing you would do is stop or look at non-opioid use and alternative practices. The problem there is most insurance does not cover chiropractor, massage, acupuncture, all these alternative other types of treatment. The second step, you would do a low-dose opioid. If that wasn't reducing the pain, then you would go to a higher dose. And then how you decide whether it's working is that patient's functioning increasing, are the side effects not affecting their life, and if once you find a dose that they are functioning adequately, you keep it on them.
Okay.
I would not have been able to have written millions of dollars of grants for my nonprofit if I had not had opioid pain relief.
In a nutshell, your experience personally sounds to me like a standard graduated interaction between you and your physician to decide what is an appropriate treatment.
Yes.
You're listening to Home Ground, and I'm Brian Kahn. We are talking about the issue of chronic pain and opioids with Dr. Marc Mentel and Tootie Welker.
If I could, I'd like to just comment on what Tootie had stated. And again, I'm in complete agreement, as well as the Montana Medical Association. She is correct. Our reimbursement system favors the use of medications alone, despite evidence supporting multimodal care such as physical therapy, chiropractic care, neurobehavioral care. We are stuck sometimes in medicine with being forced to just use medicines when really multimodal approach is the best for patients overall. In addition, MMA wrote to the CDC recommending to take away dose limitations on opiate prescribing, because the data is not there to suggest that there's one fine point that poses a specific risk. What the evidence does show, as you increase the dose, the risk increases of death, but there's no set limit. And there are people who may be fast metabolizers or metabolize it differently. There's a lot we still need to learn in the realm of chronic pain and chronic pain management.
You say there's a lot to learn, and I frankly appreciate the medical modesty of the statement. In the Federation of State Medical Boards document, there is this paragraph: model policy for the use of opioid analgesics. The FSMB encourages every state medical board to work with the state attorney general to evaluate the state's policy, regulations, laws in an effort to identify any barriers to the effective and appropriate use of opioids to relieve pain. That's a pretty strong statement, while ensuring that adequate safeguards are in place to deter and rapidly detect those who would obtain opioid analgesics for non-medical purposes. So as a layman, it's a statement: look for any barriers, get rid of them, but it's giving two messages to people. What is the status right now of those two messages? Because they go throughout this thing. I would just point out that on a couple of pages later, in detail instructions, this is bold type. These are cautionary notes. Inadequate attention to the initial assessment to determine if opioids work. Inadequate monitoring during the use. Inadequate attention to patient education. Unjustified dose escalation without adequate attention. Excessive reliance on opioids. Not making use of available tools for risk mitigation. When I read the bullet points that follow that general statement that says get rid of any barriers, if I were a doctor, I'd say, give me a break. I don't need these headaches. This is putting me at risk. Somebody's looking over my shoulder. How strong is that dynamic in this problem?
It's huge, or as Bernie Sanders would say, huge, which is why California has a Pain Patients Bill of Rights that basically puts a firewall between doctors, the DEA, and medical boards for doctors who are well trained in treating chronic pain. So there's not somebody looking over their shoulder. We want to get the same thing here in Montana. Recently, the U.S. Senate is also looking at legislation because there's a recognition that we've gone to the point that we're making it even more difficult for people who need access to opioids to get it. But what's really happening, and I've certainly found here in Montana, as you said, Brian, most doctors don't want to deal with this potential oversight, having medical boards, DEA, whatever, looking at them, so they're just deciding to quit prescribing altogether.
Mark, we've just added the United States Senate. So now we have the doctors, the patients with the problem, medical boards and organizations and oversight boards, and now I have the Senate getting involved.
You forgot the president.
Hadn't heard it that he was there, but I'll throw him in the mix. Seriously, that is an unusual mixture, it seems to me, of players. One can have a laudable goal of education, sharing knowledge as quickly and objectively as possible to improve the quality of care. That's what I understand is behind this, utilizing those 4 principles that you articulated.
Correct.
But the actual dynamic of a program often has different results. What's your assessment of what's going on, either in Montana or nationally, with this approach to try to stress education and share information versus, I will generalize, a more politicized, whether it's drug law enforcement or a politicized process?
Well, I'm a basic individual, so I like to go back to basic principles. And what I see is, again, going back, we're repeating history from back in 1914, where you had 2 opposing positions, physicians and the public. What really, I think, on both sides, you have fear. You have fear on the patient side of not having access, which I think is well-founded. You also have fear on the public side of opiates are being prescribed at unheard of amounts than before, creating a public crisis.
What is the crisis? In other words, it identifies risks of overuse,
Correct.
dependence. If we compare, we're always in policy making, comparing
Correct.
risks and opportunity. If you have people who, like Tootie, have what I'm calling acute pain, I'm told that's an improper word, intractable, severe pain, I want to say this. She said to me on the phone 2 weeks ago, if this situation doesn't change, when my animals die, I will kill myself. Now, when somebody tells you that, and I listened to her voice and the way she said it, I took it seriously, and I deeply appreciate your cooperation in this program. But when I put that sort of statement on the one side, and the public's concern about, quote, risks, unspecified, I'd go with the patient, and I'd say I trust the patient and the doctor until proven otherwise. So what's on the other side here?
Well, the part of the education, if I can go back to when we started asking the question, when patients started coming to our offices about addressing pain, what is your pain level today? The knee-jerk response at that time, if we're asking the question, there must be an answer. And the answer came in the way of overprescribing of opiates inappropriately. And there also became the idea that these medications were safe. So you would have patients diverting them between family members, friends, and with neighbors. So with that created a crisis of people addicted to opiates. That doesn't include patients who truly may have a benefit from them, but we have 2 areas that we have both sides fear. The idea is that if we can educate our providers to practice to a certain standard where they're not fearful of prescribing medicines, we also can teach our patients how these medicines may help and how may they hurt, we might reach that nice balancing point where we help those who we can, but don't harm those who might get into harm's way.
You've been practicing 22 years. You know the world you live in politically, medically. What's your projection as the chances of that happening the way you hope it will happen?
I'm hopeful, optimistic, but it's going to take a lot of work on medicine's part.
Marc is saying this is going to take time and is going to depend on a serious effort from the medical community. What's your response?
I don't have time. I'm 59. I'm tired of going into physicians and being treated like an addict, of being said that when I'm in tears because I'm in so much pain, that instead I'm exhibiting exaggerated pain behaviors. And so the mentality has become, instead of you being believed as a patient you're in pain, you're automatically disbelieved, and you have to go out of your way to prove that you're really in pain.
Okay, now, I deeply appreciate what you've said at your personal level. Do you disagree with what Marc says about, given the ambiguities and the history of this and where we are on the learning curve, that a serious educational component of the medical profession, potentially involving the patient community, is necessary for the millions of others that are in the same situation. Do you agree with him?
Absolutely, which is why there's a pain initiative coming up, and I've been working diligently trying to figure out how they're choosing which chronic pain patients will be on the panel, because I want to be on that panel, and yet I am not being given the information on how to access that.
Mark, what do you have to say to that?
Well, I'm glad Tootie brought that up, because I am the chairman right now for organizing the Montana Pain Initiative this upcoming June. And
You are joking.
I am not joking.
Okay.
However, Tootie does not know it, but after the show I was planning on asking Tootie if she would participate in the panel discussion, because her voice needs to be heard.
I'm guessing the answer is yes.
It is a very absolutely yes.
Mark and Tootie, I very much regret to say we're out of time, but I'm very pleased with the outcome of this show. Many thanks for being with us on Home Ground. And to our listeners, many thanks for being with us. We hope you'll join us next week. Home Ground is an independent production of Artemis Common Ground and does not necessarily reflect the views of this radio station. Post-production by Valtron Recording Studios.
Mine tells a good story. Hopefully that was kind of engaging. It's a little different than I know what you're used to. What I'd like to say is, after that interview that I had with Tootie, I did not know Tootie beforehand. That was not a setup, but it was a nice segue into the Montana Pain Initiative. Since then, Tootie has actually found a provider to care for her. She now gets her care at Partnership Health Center. She's following our protocols, and she's actually, I believe, thriving fairly well. Correct? Yeah.
We're getting there.
We're getting there. We're working with her. But most importantly, what we're doing is we're establishing that physician-patient relationship, working with the patient at an individual level, and finding what works for them best in a safe environment, following all the safety protocols such as urine drug screens, prescription drug monitoring, and actually seeing the patient and talking to her. How is she doing? How are we evaluating? And kind of working together collaboratively to come to that right point. It was after this interview that I finally felt, well, maybe we shouldn't throw everything in and go back to pre-1999 standards. Maybe we can keep working forward and finding a way that we can progress on managing pain, helping our patients here in the state, helping our community members, and bring up the level of, if we help those that are suffering most in our community, we bring up the level of our community and we improve our society and our community. What I learned from this, and as I think back, is I believe we're looking at the chronic pain issue from a medical model. And what I mean by that is, I think it's not a medical problem that needs a medical answer. It's a societal problem that needs a societal answer. And really therein is the emphasis of what the Montana Pain Initiative is about. Bringing everyone in society, specifically those that are in the healthcare professions, like I had mentioned before, neurobehavioralists, physical therapy, physicians, nurses, doctors, behavioral health, everyone who's in that continuum, bring them together in the same room, as well as bringing in patients and the community and community members and friends and family, and have an honest conversation about how we address pain, how we talk to people about pain, and how we manage it. So that was one of the big things I learned from it. And Tootie, if you have anything to share, this is where you said you're good thinking on your feet, so I'm putting a little pressure on you here.
Well, I think some of the stuff to pay attention to, since we instituted the Montana Drug Registry, the number of overdoses have decreased dramatically. So I think that is one tool that's really working, where doctors can look and see where all people are getting and make sure people aren't doctor shopping. The downside to that is, because some pharmacies are also getting into the role of not wanting to give out your drugs or your meds, your opioids. So it looks like you're pharmacy shopping because you go in to get it filled and they say, oh, well, we're not going to have it for another week. I don't believe that. So then you have to go to another pharmacy and another pharmacy. So then it looks up on the registry. It shows you've been to several different pharmacies when, it's not your problem. It's because pharmacists are refusing to fill. The other, sometimes it looks like you're doctor shopping, but that's because it's become so difficult to find physicians who are willing to treat chronic pain. I went from August to, I think, December with nothing, and literally spent my days mostly on the couch on an ice pack. Your world just kind of like comes, you have no life. I'm an active, like you said, I'm an active person. The thing I get chided on most by the doctors and my physical therapist is I don't pace myself. Well, that's my strategy for ignoring pain. If I keep busy, I can put it in the background. If I'm laying on the couch on an ice pack, guess what I'm thinking about? How much I hurt. That's all I'm thinking about. So to me is, having enough medicine that I can continue living an active life. I'm only 59. I'm not ready to hit the Barca lounger yet.
So with that being said, I'd like to open up questions and if not, remember I have another PowerPoint to go through, so. Yes.
You scared him.
I know.
I have a question and a comment, and the question is, I'd like to hear more about Partnership's current policy for new patients, because having practiced here, for 30 years in primary care, and now I am working in the nursing homes, and we have lots and lots of people on chronic narcotics in the nursing homes because people have pain. A lot of these are older people. We're treating osteoarthritis with narcotics because they have everything else. So we've followed all of what you're saying are the protocols, and we then have to discharge these folks, and you guys are the most available primary care docs. And we are told, no, and we're allowed to prescribe a month's worth of people's prescriptions. And after that, and it takes, understandably at least a couple weeks to get in. So I'm not saying that it's a problem getting into you guys, but we were being told, and John Miller is going to kick me for saying this, but because you told me that this problem was solved, but we're still running into it, where your clinic it's very difficult. You guys were really the people who started being the stop pain people in town. And so I understand that it's gotten better and easier, but I just want to know how easy it. So I can't get one of your docs to prescribe, once my 30-day prescription runs out, and I don't have any way of seeing those people once they leave the nursing home.
Right.
So can you address, and that's just one example of, usually an older population or a very, very disabled population. And so I actually see Partnership as remaining a barrier, but maybe I'm wrong.
Partnership is growing and learning just the way everyone else in this country is right now.
So you're agreeing with me that it was a barrier?
I agree that we're still learning, and, trying to understand what we're trying to do at Partnership, and under John's tutelage as well, we're trying to become more of a family medicine center, not a place to go to for, just for your prescriptions and then go elsewhere for your health care. We want to take care of the entire patient. Part of what really helps, is, and I'm a big believer in that. I have pain patients who, and again, we're still trying to model those behaviors and move things forward. And it's a training institution, so we're trying to move that ball. Still, as you understand with providers, there's still a lot of fear that some providers have and a lot of concerns, and they don't feel comfortable prescribing medications, and they're not familiar with how they work. There was I just saw the new CDC statistics, or CDC guidelines you've ever seen, have shown most doctors don't feel comfortable taking care of chronic pain. They don't think that they were actually trained well enough. So there is this gap of knowledge that we need to overcome. That's what we're trying to promote. And even within Partnership, we're still trying to train, and we're working on it. We're moving forward. We're going in the right direction. But it's going to take time. But one thing that can help, have you talked to, and I always find it's helpful if a patient's transferring, if I can talk to that other doctor, let them know what I've done. I don't know if that took place, but
it takes a really long time to get a hold of one of your docs, and that's true for all clinics.
Right.
That isn't a criticism, but
yep.
It's an unreal. I would love to talk to the doc so
Right.
they feel comfortable
Right.
doing that, but very often, there's a wait to get in, and they're not sure which doctor, the appointments people aren't sure who that
Right.
person's going to see. So yeah, it might be a month later that I'm talking to the doc, and I'm trying to remember who it was I wanted to talk. Anyway, so it's 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 an unrealistic expectation, I think, at this point.
Mm-hmm. I agree. I think there's barriers with, with all the newfangled ways we communicate nowadays. I don't know if we're communicating as well. That's my personal bias. That's a whole nother issue to address. But, we're trying to move in the right direction, and we really want to do the right thing by the patient and trying to follow CDC guidelines as best we can. But no, yours is not a unique situation. When I was over at Community, we had the same problems. Physicians not wanting to take on patients as well. So it's universal across and thus the Montana Pain Initiative, get folks come, learn how to better manage and understand the whole process. So
I would somewhat agree. I mean, when I told people that I'm getting my chronic pain managed at Partnership, they're like, you're kidding. Who are you seeing? Let me get to them. Because I've heard from a lot of people who've gone there and they've been said, no way, they won't treat them. So I think, luck of the draw, I got the right person who believed me right away. I've had 4 back surgeries. I'm fused L2 down. I have Ehlers-Danlos hypermobility. So I used to be like Cirque du Soleil. People could put a back bend and put my head between my legs and look up. No one told me when I was young that was bad for your back. But, I was lucky to find someone who believes me and is willing to listen. And when I say, we're getting close to the right dose, but it's not, it's still not enough for me to live the full life I want to live. Like I said, I make products, so I do farmers market every Saturday. It's not the easiest thing on my back, but again, it's also a way for me to have interact with people. I ended up having to drop out of my second master's in sociology because I couldn't get treatment for my pain, and I couldn't spend, the day being a TA, then grading papers, and then doing my own classes, and then staying up and doing research. I physically couldn't do it, but I also couldn't find treatment. And like I said, so I had my L2 fused before it was actually medically necessary, hoping that would deal with the pain, but unfortunately it's just made it worse. The other thing that people want to keep pushing is doing the injections. I've had over 29 steroid injections. Not one of them ever did anything. I'm one of the lucky few who hasn't ended up with adhesive and arachnoiditis, which there is a conference in June in Helena, and I had brochures and then I forgot them. But to deal with that specific issue with Dr. Forrest Tennant, who's kind of like known for dealing with chronic pain, but he also uses hormone treatments, he uses vitamins, he uses this whole thing, and it's also where I started learning about the CYP enzyme, and mine was tested, and I do have abnormalities, which also kind of goes in with the Ehlers-Danlos. But I think what I want people to take away is I'm so tired of being treated, that I'm guilty first and then proven innocent. We need to do like the justice system is believe people first, and then if you find out that they're not being honest, then you can deal with it. But, walking into that relationship where you're trying to build trust with a doctor, where you automatically go in going, they're not going to believe me. They're not going to believe me. I got to and then you like overdo it. And so then they're like, okay, they're faking it. They're faking it. And it's like, I've had 4 back surgeries. Of course I have pain. You think it just goes away. At some point it doesn't. But just to believe people and give them a chance.
I think that goes with and it's always hard for me as when I see a new patient and I establish and seeing them for pain, I don't have a relationship with them yet. And it's trying to build that trust relationship, find what their balance is. And, as long as I think we can develop that relationship, and that's the first thing I look at when I evaluate a patient, is this someone I can build a relationship, work with, and we come to some agreement and collaboration in how we manage their pain. And if we can establish that, I think then we have a framework in which to move forward. But that's the hard part when patients transfer, and I wish there was an easier way to get around those transfers. And communication is probably one of the best ways. And I struggle with the same thing when I have patients who transfer out of state or go somewhere else, and I hear back from them saying, no one believes me. I'm just having trouble, and it's not uncommon for me to have to continue prescriptions for a few months even when they need to stay. So it is a problem, but hopefully we can keep educating providers and we can learn more. And one thing that would be helpful if we had interstate prescription drug monitoring, so we can actually have several states be able to communicate with each other to see where the prescriptions are coming from. Yes, it helps build trust early on.
So it's my understanding that the prescription drug registry is only useful if prescribers are actually paying their fee to access it and accessing it, and that a majority of prescribers still do not use the registry. Is there a better way to help the situation? I mean, I know that the thought behind this was that we're really going to help prevent prescription overdose from controlled substances, but yet so many providers don't want to pay the fee or don't think that I don't know what the deal is behind it. I just know that it's not being used the way it was supposed to be used.
Right. We're looking at, I'm part of the MMA, so Montana Medical Association is looking at that. But, there's a lot of physicians, when you look at how many physicians across the state are using it, it's kind of skewed when you think of it because a lot of practices don't lend themselves to managing chronic pain. Mostly chronic pain is going to be in the avenue of primary care, family medicine, internal medicine. Those are going to be the big folks using it. So, as far as maybe some little bit of rheumatology, orthopedists probably aren't going to be managing chronic pain, so they might use it for their acute pain, make sure no one's using it. But there's a lot of medical specialties that just don't want to participate because they don't need it for their patient population. So my thought process, we get 50% of providers here in the state using it. We're probably getting most of the people that are prescribing. And CDC, with their 2016 guidelines, stated 50% of all opiate prescriptions are written by family medicine doctors. So that's the big chunk of folks to go for. Yes, sir. Oh, Robin, right behind you. I don't think Frank has.
Put him on the spot.
Yeah, I'm a sufferer of pain. I have moderate to severe stenosis in my neck. I have scoliosis, and just about every joint has osteoarthritis. Some are starting to diminish. The joints are wearing away. And what's helped me a great deal is the pain school here. I want to put in a word for it. I went yesterday, and the sad part is it seems underutilized.
Right.
Sometimes you go into just one person, sometimes there's only 5, and it has helped me greatly because you find out you're not alone. Because nothing's lonelier than having an attack in the middle of the night. And there's other people there, and they are just great up there. That's at the Spine Center. I don't know how many people know that it exists. And strictly as a patient, it's been a revelation for me. Between that and physical therapy, I have my prescriptions of hydrocodone actually expire past the date because I just don't have to use it anymore. I have my bad days, but I just want to put in a word for the pain school and that approach. Thank you for having this morning.
Yeah. Just to dovetail on that, so people don't, I'm not a huge advocate for opiates as the sole solution, but I am an advocate for it. They may be a tool that could be assistance. Really, when you look at it, physical therapy, movement, those are all things that help chronic pain. I'm an osteopath by training, so our belief is the body can self-heal if we just give it a chance. And the way I look at pain medicines, they're just there to help you get moving so we can get the motion going. Right. Right. My philosophy is low doses, go slow, and usually immediate release are the more common ones, just because sometimes when you're a chronic pain sufferer, all you really want to do is get a little break from your pain, just get a little relief so it's not always there. And I think with using that, I've never had problems with patients developing tolerance with the short acting, and they've been able to maintain their days. They've been able to pace themselves, which I think Tootie has a problem pacing herself, as you can tell, with all her masters and everything else she's trying to. You need to moderate more.
I'm a Scorpio. We either do or we don't. We don't know middle.
But moderation is the key. Still there's no cure for these degenerative conditions, but what we can do is learn to pace, learn other ways of distraction, other things that are important. But as we went and talked about in Brian Kahn, there's also insurance changes that need to occur so these modalities are available to more patients because they really do help. And sometimes patients are just locked into, all we can do is your medicine because I can't get, with Medicare, you're only allowed so many physical therapy treatments a year. my insurance won't pay for this modality, so I'm locked into this. I run with these insurance issues all the time.
Medicaid won't pay chiropractor, which is the one thing that keeps my L1 from the finally blown, and they told me when that goes, they're going to fuse me T10 down. I'm very hypermobile, which is part of my problem, so that's the other thing about not being believed is, when I say I'm fused, my whole lower spine, and then I walk in all loosey-goosey, people are like, no way could you have this much movement. My physical therapist is constantly going, I don't know how your body moves as much as it does when you're fused your whole, half your spine. But it was a curse and a blessing because I could still put my hands flat on the floor. If I was stiff like some people living alone with just my critters, I'd have a lot harder time.
So just to remind you, I'll talk to your doctor and make sure you come in for osteopathic manipulative treatment. So, well, no, we do. We have a clinic for.
Okay.
So I will talk. I know who to
Okay.
talk to. You're coming in. We'll be seeing you shortly.
Okay, that would be great.
So again, reminder on the date: the Montana Pain Initiative is June 10th and 11th. It's a Friday and Saturday. We have a guest speaker coming from in Texas who does a pain rehab school. She's a chronic sufferer of pain, deals with opiate addiction, and as well as maintains or manages chronic pain. And she does a prescription rehab school for across the country for people to learn how to prescribe better. So I thank everyone for their time and have a good day.
Thanks.